guys to another class on physical doctors on the Infex. So today we are going to study about the hip joint. Yes. So now we are going to study the hip joint. So first of all, before going to hip joint, let's have a look at a photo of the hip joint. See, we are going to take this photo. We are going to take this photo. Wonderful. And copy it. We are going to go over to a note, and we are going to paste it. This. Yeah, it's done. So this is a cross section of the hip joint, coronal section of the hip joint. Right, a coronal section of the hip joint. Coronal section of hip joint. Now, if you want to draw this diagram, it's very easy diagram. You can just draw it. I'm not drawing it because I've already taken the picture, so it's easy and a bit quick for me if I show it like this. But this diagram is important. You should be drawing it. Okay, so some basic points about hip joint which you must write. Multi-axial. You have to mention. Axial, ball, and socket. Like that. Synovial joint. Now, coming on to the main important point, bones forming the joint. Whenever it's the topic about joint, it usually is a long question because a lot of information is restricted. Ball. If it's a ball and socket type of joint, we have a ball, we have a socket. Represented by head of femur. By head of femur. See, you can see the head of the femur. I hope you can see it here. This part. So this is the head of the femur. It represents the ball. It is 2/3 of a sphere. All these points are important. Okay, this is the bare minimum that you can write if a question comes regarding the hip joint. Articular, completely articular except pit or phobia in its center. You don't need to draw the picture of the pit or phobia, though I'll show it to you. And it's covered by hyaline cartilage. Hyaline cartilage, which is thickest in center and thinnest at periphery. Now let's have a look at the other photo which I was telling you about. So as you can see, this is basically the socket. But what we can show here is that the socket, but at least you can make out now. You can make out that this is the part which is covered with articular cartilage, and this is the part which has no cartilage covering it. Sorry, this is the part which is called articular cartilage. This is the part which is non-articular. Non-articular. You don't need to specifically draw this image. There is another image which is very important. This one, I'll talk about it when we come to it. So what you have to understand is this part is articular. This part is non-articular. Wonderful. Let's go back. Socket. So as I told you, first we talked about the ball, now we'll talk about the socket. What's the socket? Let's have a look. This is the socket. This is the socket. Acetabulum of hip bone. Articular surface. Articular surface is horseshoe shaped, as I showed you. Lunate surface. Thickest is posterior superior part. Okay. Finally floor, non-articular. So I'll go back to that image again, okay? Also known as the acetabular fossa. Filled with fibrofatty tissue. I have to go back to that image again. Wonderful. Acetabular fat. This is an important fiber point. Acetabular fat is intracapsular, but extrasynovial. Okay, extrasynovial. So let's have a look at the image once again. If you go back here, you can see that this part. This image is superb, and it just describes acetabular fat. So I hope you remember that this is intracapsular, but extrasynovial. Okay, extrasynovial, wonderful. This part is the articular part, as shown, lunate articular surface of the acetabulum. Okay, you can see the acetabular branch of the artery coming here and dividing. Okay, we can bother about that a bit later. Okay, if we usually go through the clinical anatomy part of the fracture of neck femur, then there is transverse acetabular ligament of head of femur. These are the other ligaments which we will talk about shortly. So this part is the floor which is non-articular, and it's filled with fibrofatty tissue. So let's go back to our notes. This is the ball and the socket which we talked about. Now going over to another point over here. Acetabulum presents a notch below, which is bridged by transverse acetabular ligament. Now going to another point. What are the ligaments of the joint? You can see here some ligaments have been mentioned. Ligament of head of femur. Okay, the transverse acetabular ligament, zona auricularis, some retinacular fibers, fibrous capsule. Very important. Let's go back. Capsular ligament with synovial membrane. Okay, with the synovial membrane. Then moving on to acetabular labrum, and transverse acetabular ligament. Transverse acetabular ligament. You don't need to worry, as I'll show you another picture. Though this picture is not much important. If you have time, you can definitely draw. I have to show you for your understanding. Ligament of head of femur. Finally, the three ligaments: iliofemoral, ischiofemoral, and pubofemoral. Okay, let's go and bring that picture over here. This is my picture. Yes, let me have a complete look at it. First of all, yes. So this is the picture that I was talking about. So let's first of all bring it to our main document. Okay, done. So we copy the image and we bring it to our document. Here we paste the image. Here we paste the image. So not much of an important image as far as this answer is concerned, but then you can always see this is an important image. I marked it. This is not so important. So let's have a look. First of all, there is the capsular ligament with the synovial membrane. This is not shown here, but you have to know any joint you're talking about. You have to mention about the capsular ligament. Very important. Then acetabular labrum. This is also not shown here, but this is the transverse acetabular ligament you can see, and the acetabular labrum usually goes around it to deepen the joint like this. Okay. So let's go back. Ligament of head of femur here. Finally, the iliofemoral, ischiofemoral, and pubofemoral ligaments. This one, let me mark this. Iliofemoral ligament. You know why I marked this? Because this guy is important. He may come as a short note. Or maybe, okay, this ligament is important. It may come as a short note, and you have to be very particular about this ligament. Let's have a look at the photo once again. See this one. This photo, I'm just going to bring it in for you guys a little bit later, right? Not right now. If you can see here, you can see that I have the ischiofemoral ligament over here, and I have the synovial membrane. Though the pubofemoral ligament is shown in this diagram, and finally we have iliofemoral ligament, which is usually actually represented as this. So it's like a Y-shaped structure. You can see it goes like this. Okay, so let's go back to the main document. So then we are going to go over if it's a joint, we have to talk about its movements. So we will now talk about the movements of the joint. What are the movements possible in any joint? Flexion, extension, adduction, abduction, and along with that, some joints also offer medial rotation and lateral rotation. Medial rotation, lateral rotation, and any other muscle, any other movement. You have to mention what are the range of movements, what are the muscles that are associated with the movements. Finally, you have to mention about the nerve supply and the blood supply. So let's get into it slowly. Flexion and extension take place around the axis of neck of femur, which passes through femoral head 90 to 100 degree of range of movement when knee is flexed. When knee is extended, sorry, my bad. When knee is extended up to 120 degree when knee is flexed. See, this is easy for you. If your legs are straight, can you pull your legs straight up? It's difficult. But if you flex your knee, if you bend your knee, you can definitely raise your legs to a higher level, right? You maybe be doing jogging and all that, or an exercise, cardio exercise, they're called high knees. So how do you bring your high knees? How do you bring your knees to that height? You have to flex your knees so that you can raise your legs much higher, right? Why is it so? Okay, sorry. So flexion. What is the action of flexion? What does flexion do to the joint? It makes the joint loose back. Flexion movement makes the joint loose back. Capsule is relaxed. Now what are the muscles that bring about the movement? Iliopsoas. It's the prime mover. Assisted by pectineus, rectus femoris, sartorius, adductor longus, only in initial phase, not throughout the movement. Let's go to extension. See, if it's a joint, you have to write so many details. Okay, I know it's a bit irritating, but then you have to write these details. This extension is limited when thigh and trunk are in vertical line. 10 degrees to 20 degrees beyond vertical line, usually arrested by tension of iliofemoral ligament. See, iliofemoral ligament is so important. Okay, iliofemoral ligament is the only ligament which prevents you from falling backwards. Can you tell me a ligament which prevents you from falling forwards? That ligament is the Achilles tendon. Sorry, it's not a ligament, it's actually a tendon. Okay, my bad. So Achilles tendon prevents you from falling forwards. It is the strongest and the thickest tendon of your body. It is the Achilles tendon. So if the Achilles tendon is cut, you will fall forwards. Okay, and if the iliofemoral ligament is cut, you will fall backwards. Now let's go. Ligaments are maximum spiraled and taut when extended. Okay, head is screwed home. See, let's highlight this line. It's known as the screw home action. Wherever you find the screw home written, again you'll come across it in the knee joint. You have to remember this. They might ask you a question. When is the hip joint screwed home? So this is in extended position. Okay, then they might ask when the knee joint is screwed home. So that time also you have to answer like that. Joint is closely packed. So in flexion, the joint is loosely packed. Here the joint is closely or tightly packed. What are the muscles? Glute max and hamstrings when against resistance. That means if you are running that time. Otherwise normally, my bad. Yes. So yeah, glute max against resistance. When you're running, your glute max comes into play. Okay, your glute max comes into play. But hamstrings in normal movements. Normal movements like walking or standing, that time your hamstrings come into play. Now we move on to the next movement, that is adduction. Adduction and abduction. See, already we have written 1 page, now we are going over to 2 pages, probably will consume up to 3 pages. adduction take place in anterior posterior axis, okay, in anterior posterior axis, passing through head of femur, passing through head of femur. It is limited by, see, adduction is limited by opposite thigh. You see, you can't bring your legs inwards too much at your two legs. Okay, then lateral fibers of iliofemoral ligament of head of femur. Okay, but however, in semi-flexed thigh, this movement is more pronounced. Okay, what are the muscles? Adductor longus, brevis, adductor brevis, and magnus, adductor fibers of adductor magnus, assisted by medial fibers of pectineus and gracilis. Done. Abduction, more pronounced. Okay, it's more pronounced compared to adduction, so you can abduct your legs much more. Prevents unsupported side of pelvis from drooping. So if you see this now, I will underline this, okay, because this will bring us to an important clinical anatomy question known as Trendelenburg sign. Okay, it's known as Trendelenburg sign. I'll come to it later, not right now. Okay, so the muscles are anterior part of gluteus medius and minimus. Just remember this one now. Okay, tensor fascia lata and sartorius muscle. Okay, now we go on to another movement, which is the medial and lateral rotation. Medial and lateral rotation occur around a vertical axis, passes through center of head of femur to lateral condyle of femur when foot is on ground, but through any point, foot above ground. See, what you have to understand now is that whenever I talk about a movement, you have to try to always mention its axis. You have to try to mention its axis of movement. Okay, so let's go over to medial rotation, lateral rotation. So I hope you understand what medial and lateral rotation is. Okay, let's go over to the muscles. Medial rotation, anterior fibers of gluteus medius, minimus, tensor fascia lata, and all the abductor muscles. Psoas major only when foot is on ground. Lateral rotation by gluteus maximus, piriformis, obturator internus, externus, two gemelli muscles, superior and inferior gemelli, and the quadratus femoris. Okay, now we go on to another point, that is the blood supply of the joint. Moving on to the blood supply of the joint, we have to remember what are the arteries. Medial and lateral circumflex femoral obturator artery, superior and inferior gluteal artery. These are the arteries that mainly provide the blood supply. So mainly we are concerned about the neck and head of femur. Because those are the parts which are involved in the joint. So neck and head of femur receive blood from. We have an important clinical anatomy question also coming from this. So let's write it down. Acetabular branch of obturator artery. I hope you remember that. Let's go back to the picture. See, you can see it here. Okay, so its course you have to mention enters through gap between transverse ligament and notch, supplies acetabular fat, and provides a branch medial epiphyseal artery, accompanies ligamentum teres femoris, or the head of the femur, ligament of head of the femur. See, again going back to the picture, you can see that this is the ligament of head of femur. Yes, ligament of head of femur. So this is basically going on. See, if it covers up, so it will look like this. So it is mainly going along this path. So that's why they say that it accompanies the ligament of head of femur. Let's go on to the next point. Branches of medial circumflex femoral artery. They pierce capsule and accompany beneath the synovial membrane along the retinacular fibers. I think there's some problem in my pen. Okay, I can't. It's okay. Retinacular fibers. Let's go over and see the retinacular fibers. Can you see them? So these arteries basically they come from here and they go along these lines. Okay, they come from here and they go along these lines. They circulate the femur. See these lines? You can see that they go along these lines. Okay. Okay, let me just erase it now. Yes. So they go along the retinacular fibers and supply superior aspect of neck or femur. Few terminal branches enter head of femur proximal to epiphyseal cartilage and supply upper and lateral part of head as lateral epiphyseal artery. Yes. And the branches of medial circumflex femoral artery. See, once again we are bringing this medial circumflex femoral artery. They accompany the reticular fibers along inferomedial aspect of neck, supply lower or metaphyseal part of head of femur. Now we may have a small applied anatomy part coming up, but I will cover it later. Okay, let's mark it in red or orange or red. Okay, why we are marking it in red? Because we have to remember this one. Okay, it's coming later up. I'll not cover it now. Okay, see what are the okay, I'll talk about it later on. Okay, the applied anatomy incomplete. I'll talk about it after the basic discussion is done. So let's go over to the nerve supply of the hip joint. Nerve supply. Femoral nerve via nerve to rectus femoris. Obturator nerve, anterior division and accessory obturator nerve to quadratus femoris. Some twigs from sciatic nerve, superior gluteal nerve. Now we'll go on to another part. See the L2, L3, L4, L5. These are the segments which control hip movements. Okay. See this. L2 and L3, they mainly control flexion, adduction, and medial rotation. Okay. L4 and L5, they control extension, abduction, and lateral rotation. Okay, let's go on. Now, what I want to show you is one image. Okay, one image I want to show you. Yes, this one. It's not that important of an image. That is this one. See, this is the relations of the hip joint. If you have extra time, you may draw this and talk about the relations of the hip joint. But when it comes to a question relating to joint, its relations may not be mentioned. Okay, they're not that important. Let's go over to the applied anatomy part, which I had been talking about, and just circling it backwards. So let's go to the applied anatomy part. First of all, something that I want to really talk about is, and what you should know is, the Trendelenburg sign. The Trendelenburg sign. This is the applied anatomy part. It's basically related to the muscles. So we'll talk about the Trendelenburg sign first. Then there are a lot of this clinical anatomy part which can be mentioned. But first of all, we have to talk about the Trendelenburg sign. And then we also have a coxa vada, all those things. But first of all, we'll talk about the Trendelenburg sign. So let's see. Trendelenburg sign. So today we'll discuss about the Trendelenburg sign. As I told you, it is basically the stability of the hip joint when one foot is raised above the ground. So when one foot is raised above the ground, usually that part of the pelvis, it goes a bit up in order to stabilize the person. So how does it go up? It is due to the gluteus medius and minimus of the opposite side. Okay. So suppose that the gluteus medius and minimus are defective. What will happen then is that the person's this part will sink. So it will be looking like this. This side is defective, but this side is healthy. So the healthy but unsupported side will sink down. This is known as Trendelenburg sign. Moving on to other problems of the hip joint. Okay. Moving on to other clinical anatomies of the hip joint. What we are going to cover after this is coxa vada. What's coxa vada? Neck shaft angle is reduced, is decreased. Okay. Now there may be many reasons. Okay. Maybe many reasons, but you don't need to know what this. Those are pathological. Mainly this you have to know what is coxa vada. Congenital dislocation of hip joint. Mainly occurs in women. Okay. Why it occurs? Because lateral wall of pelvis is more vertical. Acetabular cavity is shallow. Okay. And the shelf-like buttress of upper part of acetabulum is poorly developed. Acetabulum is poorly developed. developed. Okay, so the femoral head is dislocated towards the gluteal surface or posteriorly. Another thing you can write here is you wrote about coxa varana, you can write about coxa valga. Coxa valga is also a contributing factor in this. Okay, coxa valga is present, then also congenital dislocation of the hip joint member. What is it? The neck shift angle is usually exaggerated. Angle is exaggerated, which means increased. Okay. After that, now we are going to talk about the fracture of the neck of femur. So coming on to the fracture of the neck of the femur. Femoral head mainly receives blood supply from three sets of arteries. Nutrient artery, which travels up the diaphysis. The retinacular arteries, which we have already discussed. So mainly the medial circumflex femoral artery, lateral circumflex femoral artery, they usually travel along the retinacular fibers. So they form the retinacular set of arteries, which is the main source of nutrition for the neck and head of femur. Coming to artery of head of femur, is a very negligible source. Okay, so since the retinacular arteries play a key role in providing nutrition to head and neck of femur, so when these arteries are somehow injured, then only there can be a chance of damage to death of femoral head, avascular necrosis of femoral head may occur. How are these arteries damaged? Usually when the neck of the femur is fractured, mainly in intracapsular fractures. Okay, now I want to show you an image. It's from Vishram Singh. Okay, Vishram Singh's clinical anatomy. So insert this photo. Yes. I can't make this image more big. I can't even crop it actually. I can't crop it. No, there's no nothing available for editing the image, right? No, I can't edit the image. Can I? Let me check once. I can't edit the image. It's okay. It's okay. Let me see. I've got the selection to write. The selection. Yes. Copy to clipboard. Paste from clipboard. Here I paste it. About this. Okay. Yes. So what you can basically see is that these are the retinacular arteries. Okay, this is the capsular retinaculum, this is the nutrient artery, and this is the artery of head of femur. This is the part-1 type of fracture, basal type of fracture, cervical and subcapital type of fracture. So you can see that this fracture, no problem. Head is secured by these arteries. But this type of neck femur fracture, these arteries are disconnected, so the main supply is lost. Thus, the femoral head gets damaged. Okay, thank you. Now we'll continue with the knee joint discussion on the later lectures. So now we're going to discuss about two more topics from the hip joint, which are basically a part of the hip joint, two ligaments of the hip joint. The one is the acetabular labrum. This is a bit different because other ligaments are hyaline cartilage, but this is fibrocartilage. So it's a fibrocartilaginous rim. So fibrocartilaginous rim. If a separate question is asked, then only we will write about all this. Otherwise, in the hip joint, you don't need to mention all this. So it's a fibrocartilaginous rim and triangular in cross section. Okay. It not only deepens the socket, but it grasps the femoral head tightly beyond the equator. Femoral head tightly beyond the equator. Okay. And when? Yes. So femoral head tightly beyond the equator. Next point is when fibrous capsule is disconnected. So suppose the fibrous capsule got damaged or disconnected. Capsule is disconnected. This labrum retains the head in position, retains femoral head in position. In dislocation, in posterior dislocation actually, in posterior dislocation of the hip joint, free margin of labrum, I'll just show you what it is. Free margin of labrum may be outturned or inturned. When it's inturned, surgical correction creates difficulty. Now let me show you what the acetabular labrum looks like. So we go back to this photo, this diagram, and if we have a look at this photo, let's bring it to our area. We can copy the image, we can paste the image. This you have to draw this diagram if a separate question regarding acetabular labrum is asked. We can write acetabular labrum. See, the rim is showing acetabular labrum. Here you can see the part where the head of the femur gets attached. Okay, you can see the transverse acetabular ligament. This part is important. You can see the acetabular labrum, usually triangular in cross section. Now moving on to the iliofemoral ligament, also known as the ligament of Bigelow. Iliofemoral ligament, also known as the ligament of Bigelow. So what I'm going to do is I'm going to show you a picture. I'm just going to start off with the picture first. Let's bring it into our area. Let's paste the image. Here we will have it. This is the iliofemoral ligament. You can see the two rami or two fibers of the iliofemoral ligament. So let us get into its details quickly. Iliofemoral ligament is the strongest ligament of the human body. And what is the strongest tendon? I told you the strongest tendon is the Achilles tendon. It strengthens anterior part of fibrous capsule of the hip joint. Inverted Y shape. It has an inverted Y shape. The stem, that is this part, stem, attaches to anterior inferior iliac spine. Base diverges as medial and lateral bands. A medial band and a lateral band. Medial band attached to lower part of intertrochanteric line. Intertrochanteric line. Lateral band attached to a tubercle in upper part of intertrochanteric line. Smooth. There is an intermediate stratum pierced by ascending branch of circumflex femoral artery. This intermediate stratum, this one. Okay, yes, this one. This triangular intermediate stratum is pierced by branch of ascending branch of circumflex femoral artery. So what is the functions? In anatomical structure, we have to know its functions. In erect position, posture, line of gravity passes slightly behind centers of both femoral heads to prevent natural tendency of backward tilting of pelvis. Anterior part of capsule of the hip joint is made strong by this ligament. Tension of iliofemoral ligament prevents hyperextension of hip joint. What is the applied anatomy from this part? Intact iliofemoral ligament in dislocated hip acts as fulcrum to set head in acetabular socket. Smooth. So, hello and welcome guys to a discussion on the knee joint. So, coming to the knee joint, what are the things that we are going to discuss? First of all, we are going to discuss the basic points, like in the previous one, some points, then the bones forming the joint, then the functions of a special bone, then the ligaments of the joint, the movements of the joint, some relations of the joint, arterial supply, nerve supply. Then we also going to discuss the locking and unlocking mechanism, which is a very important question when it comes to the knee joint, may come as a separate question. I think it's better if I cover that one separately. Also, some clinical points we will discuss, and in these clinical points, I would also like to include the Q angle. So, Q angle is actually a clinical anatomy which would fall under the quadriceps. Actually, I would mention. I remember that I had also mentioned about the Trendelenburg's sign in the previous class on hip joints. So, when it comes to Trendelenburg's sign, let me write it down. Trendelenburg, you should always mention it as a clinical anatomy, under the gluteus muscles. Okay, under the gluteus muscles. The same Q angle should be mentioned under the quadriceps muscles. Okay, so yes, a Trendelenburg should be mentioned under gluteus muscles, though you can also mention Trendelenburg in hip joint, but it's better to mention under gluteus muscles. And Q angle is specifically to be mentioned under the quadriceps only. Okay, I'm teaching it here, but you should be particular about mentioning it under the quadriceps. Okay, so let's get started. We'll write down for some basic points. Knee joint. It's a compound, complex, synovial joint. 3 primitive joint cavities are present. Femoropatellar, medial and lateral condylar. Why it is known as a condylar and modified hinge joint? And you know, in our human body there are no normal hinge joints present. All the hinge joints that are present are modified hinge joints. So it's a modified hinge joint. Transverse axis of movement is not fixed. Transverse axis of movement actually changes its position. We will come to know that in the locking and unlocking mechanism part. Moves forward during extension and backward inflection. Good. There is some conjunct rotation also of femur on tibia and vice versa. I wish that I could have shown you with the bones with this locking and unlocking mechanism. It's very interesting and very fascinating. Okay, and you know, it always like it goes on in your mind. What is the mechanism? If I can't see it, I can't visualize it, I won't be able to understand it. Right? I'm trying my best to make it understand. So now moving on to the other points. The bones forming the joint. Bones forming the joint. Condyles of femur. Condyles of tibia. Articular surface of patella. Coming to a special point only concerned with the knee joint, that is the functions of patella. If a short note comes regarding patella, though not It's a very rare situation, but still if a short note comes regarding patella, you may write this also. Protects knee joint from the front, hinders beginning of extension from extreme flexion as it is sandwiched between advancing femoral and tibial condyles. Facilitates end of extension by keeping ligamentum patelli away from transverse axis of joint and increasing momentum of quadriceps pull. Coming over to ligaments of the joint, I believe here is a nice picture. So first of all, you have to write about the capsular ligament, which is not shown over here. Ligamentum patelli also you have to write about it. Tibial and fibular collateral ligaments. The fibular, tibial collateral ligaments. Yes. Oblique popliteal and arcuate ligament. It's not shown here clearly. Let's see if I can show you a picture. No, I don't have a photo regarding that. Anyways, so oblique popliteal and arcuate ligament is present. Let me see if I can get one for you. Usually the oblique popliteal ligament and the arcuate popliteal ligament, they are present in the posterior aspect. Okay, so yeah, we got the photo. So let us have a look at it. Yes, I think we can now have a look here. So you can see that this is the posterior aspect of the joint. So here here, let's keep it here. Yes, so definitely with the laser pen I'm showing you oblique popliteal ligament, okay, and the arcuate popliteal ligament. This is the arcuate popliteal ligament and this is the oblique popliteal ligament. It's cut right in this photo, so let us note them one by one. Capsular ligament and synovial membrane, ligamentum patelli, tibial and fibular collateral ligament, oblique popliteal and arcuate ligament, anterior and posterior cruciate ligaments. Very important, okay, we'll discuss about it separately. Let's see if I can have a photo of the cruciate ligaments. Here is the anterior cruciate ligament, here is the posterior cruciate ligament. Anterior, posterior. Wonderful. 6 is the coronary ligament, transverse ligament, and meniscofemoral ligament, which connects the meniscus to the femur. And finally, we have the medial and lateral menisci. You know, these are also very important. Coming to the movements of the joint. So if you look at the movements of the joint, we would have this extension, flexion, medial and lateral rotation. Extension first. At extreme extension, joint is closed back and locked. In a locked position, the nutrition of articular cartilage is maintained. Asymmetrical standing. And asymmetrical standing, joint is fully extended over short period. Extension range. The range we have to write about it. It is 5 degrees to 10 degrees. Mainly the muscles, quadriceps femoris, assisted by tensor fascia lata. Flexion. Range of motion 120 degree extended hip and 140 degree flexed hip. Muscles, semimembranosus, semitendinosus, biceps femoris. Initiated by popliteus. It begins the unlocking mechanism initiated by popliteus. I hope you remember that from the class on popliteus. Medial and lateral rotations. It may be conjunct or adjunct. Conjunct rotation takes place automatically during flexion extension. Adjunct rotation takes place in semi-flexed knee by active contraction of muscles. it has a range of 50 degrees to 70 degrees. With this, we come to the relations of the knee joint, the bursa around the knee joint. I tried finding a photo of the bursa around the knee joint, but I was not able to find in the books. Let me just check if one is available in the net. Yes, few are available. So let me bring them down for you. Yes. Done. So let's show them to you one by one. Actually, I'll insert these two photos. It's a wonderful clinical anatomy regarding the bursa around the knee joint. Yes. So in front. Yes, in front. Subcutaneous pre-patellar bursa. This one, they're showing it in frame, but it's okay, just understand the location. Between skin and anterior surface of patella. If this gets inflamed, what's the applied anatomy? If this bursa gets inflamed, it's known as the housemaid's knee. Next we have subcutaneous infrapatellar bursa. Between skin and tubercle tibia. If this gets inflamed, what happens? Clergyman's bursa. See, you know the clergy. What is the clergy? It's the church, right? So in the church, you know those wooden tables are there where there's a knee stand below where you actually kneel down and pray. So that is what happens. If you kneel down and pray for long, this bursa may get inflamed, leading to clergyman's bursa. That's what's called clergyman's bursa. Housemaid's knee. See, you know housemaids they clean the floors with the mop and they kneel down and clean. Okay, they bend over and clean. So that can lead to inflammation in the pre-patellar bursa. So this is infrapatellar bursa. Pes anserine bursa is also written here, but it is actually a bursa surrounding the anserine muscles. Okay. Of the insertion of the sartorius, then the gracilis and the semicranial muscle. Okay, you don't need to bother about this bursa right now. Then we have the deep infrapatellar bursa. See here they have shown subcutaneous infrapatellar bursa and deep infrapatellar bursa. Behind ligamentum patelli. See this behind ligamentum patelli. See this is the ligamentum patelli. That's behind the ligamentum patelli. Behind ligamentum patelli and in front of anterior surface of upper end of tibia. Suprapatellar bursa. Between quadriceps femoris and lower end of femur. Let's have a look. Is it present here? This was in the suprapatellar bursa in both images. Sure. Now we have some bursae which are present laterally. 4. Between the lateral head of gastrocnemius and capsular ligament and capsule of the joint, between tendon of biceps femoris and fibular collateral ligament, between fibular collateral ligament and popliteus muscle, between lateral condyle of tibia and tendon of popliteus. Medially, we have 4 bursa present. Medial head of gastrocnemius and capsule, between tibial collateral ligament and sartorius gracilis semitendinosus. This is the anserine bursa. Okay, I was telling you it's the anserine bursa, this one only. Then superior and deep part, superficial and deep part of tibial collateral ligament. There also bursa is present. And between insertion of semimembranosus and medial condyle of tibia. What is the arterial supply of the joint? I hope you remember the class on genicular anastomosis. The same arteries, genicular anastomosis. Done. What is the nerve supply? 10 nerves. 3 from femoral nerve to vastae, 3 from tibial nerve, superior and inferior medial genicular nerve and middle genicular nerve, 3 from common peroneal nerve, superior, inferior, lateral and recurrent genicular nerve, and 1 from posterior division of obturator nerve. Let us go into the segments L3, L4, L5 and S1. L3 and L4 they regulate extension, L5 and S1 they regulate flexion. So with this we have come to the end of the basic discussion on the knee joint. You can see it has already consumed around 3 pages. So basically the basic discussions are over. Now we can move on to some clinical correlates, after which I'll be covering the locking and unlocking mechanism. So first of all, going to the clinical correlates. I'll go on the next page, clinical anatomy. So the clinical anatomy that we can write about is the genu valgum, also known as knock knees. Knock knees. Right. So if the angle between long axis of femur and tibia is less than 165 degree. Genu valgum, Bolex, also known as Bolex. Angle between long axis of femur and tibia is more than 180 degrees. What's the normal value? Normal angle 170 to 175 degrees. Okay. What are some other clinical anatomies that can be given? Now coming to the specific clinical anatomy which I was talking about, that is the Q angle. What is the Q angle? This should be specifically mentioned as under quadriceps. It's also known as quadriceps angle. I'm telling it here, but we should mention it under quadriceps. I'm telling it here because it is connected with the patella also in some parts. So let me get to it. Q angle, it is mainly formed by the line of pull of quadriceps femoris muscle and ligamentum patelli as they intersect at the center of the patella. How to demonstrate it clinically? Represent it as intersection of a line drawn from anterior superior iliac spine to center of patella, and another line from center of tibial tuberosity to center of patella. This angle is more in females due to a wider pelvis and a greater deviation of femur from long axis of leg. Normal value 10 degrees for men, 15 degrees for women. What's the clinical importance of this angle? Excessive Q angle means patellar subluxation or dislocation. You don't need to explain much more. Why is it so? Why does it mean that there is a patellar subluxation or dislocation? Because as the Q angle increases, patellar tends to move away more laterally as the quadriceps muscle exerts greater force on the patella. So how to draw this? So here you can see is the anterior superior iliac spine. Here is the center of the patella. Here is the tibial tuberosity. Okay. So if I take a line and I join these 2 points. Sorry. Right. So where they intersect, this will be the Q angle. Okay. If I extend this above, then this is going to be my Q angle. Okay, so this is the Q angle. I hope I could demonstrate the Q angle nicely. So moving on to these parts. So the clinical parts have also been demonstrated. Now remains some of the ligaments, some important ligaments that are worthy of mention. So now we are going to discuss the locking and unlocking movement sequence. So when it comes to the locking and unlocking movement sequence, we're going to first discuss this, then we're going to go over to the few ligaments that were left. So because the ligament part also contains some clinical anatomy. This is a small part and we can cover it. Very detailed part, very important part, may come as a short note or explain type of question on its own. Okay, on its own. So let's get cracking once again. The first thing is I want to insert an image. this. First of all, I want you guys to look at the situation. Look at this situation right here. I want you to look at this situation right here. This is a case of extreme flexion. Here you can see the convex parts of the femoral condyles are resting on the posterior horns of the menisci. I hope you can see this is the convex part and this is the end of the menisci. Now as the extension starts, first of all, this happens. This thing just rolls forward. It doesn't go like this. First it goes like this. Slides in front, rolls forwards. Easy. Then it stops rolling. How does it stop rolling? By due to the action of one ligament. I'll come to it. But you have to know that it stops rolling or stops sliding. Just stop. Okay. Now, this is the transverse axis. So the transverse axis travels this distance and it's fixed here. When this transverse axis is fixed, then this movement starts. So now it begins to spin forwards and starts to become straight or starts to extend properly. Now what happens is that when it comes up to this position, the lateral compartment, the lateral meniscofemoral compartment is completely covered. Okay, but the medial meniscofemoral compartment remains a little bit uncovered. Okay, so just 30 degrees there is a conjunct rotation, either some medial or lateral rotation that depends on the position of the foot. So by this way, the entire meniscofemoral compartments are covered and the knee goes in a completely extended or locked position. This is known as the locking mechanism or the screw home movement. I will mention about it. Why am I focusing on this? Because it's an important Viva question. Screw home movement. The joint is locked, ligaments are stretched, joint is maximally congruent. These lines are very important. I will write them down. And the extensor muscle sees active contraction. When flexion starts, so this goes back again. The joint has to be unlocked by the lateral rotation of the medial femoral condyle, and the popliteal muscle also helps. Now let's get into it step by step. First we will go in this direction, then in this direction. Let's start. Step 1. Extreme flexion. Both femoral condyles rest on posterior horns of both menisci. This part. Step 2. Both femoral condyles roll forwards on upper surface of both menisci. And transverse axis of joint moves forward. We are talking about this movement. Moving on, step 3. Forward movement is arrested. And it is arrested by tension of posterior part of fibrous capsule, oblique popliteal ligament, and posterior cruciate ligament. Step 4. Along the fixed transverse axis, both femoral condyles spin forward. Step 5. Lateral meniscus is shorter than medial meniscus. In anterior posterior extent. Thus, lateral femoral condyle occupies lateral meniscofemoral compartment earlier. At this stage, complete full extension falls short of 30 degrees. Okay, and the anterior cruciate ligament is stretched, which acts as a vertical axis, along which the medial femoral condyle rotates backwards and medially and occupies medial meniscofemoral compartment completely. Okay, so and this last 30 degree, this is known as the locking mechanism, locking or screw home movement, which is very important Viva point. Screw home movement. In this case, what you have to know is that the joint is locked, so ligaments are stretched. As I told you, the joint is maximally congruent, and extensor muscles cease active contraction. This part is very important. Okay, this part is important. Now coming to the other part. See, this is extended extension from flexion. What about the other way around? It is flexion from extension, flexion from locked position. This is also what you have to know. So when flexion starts, joint is first unlocked by lateral rotation. So that time it was rotating medially, now it's rotating laterally of medial femoral condyle around the axis of anterior cruciate ligament. Okay, so now you can see that popliteus initiates flexion. Popliteus initiates flexion by unlocking the locked knee. The locked knee. How does it do that? Pulls the lateral meniscus backwards. Okay, so that's how it is done. Now if you want to go into the details of it, it's just a reverse of these things. So how are you going to write? So first of all, I'm just saying it, I'm not writing it because question like that does not usually come. Usually you can explain that and then give these points. What I'm telling you is that first the joint is unlocked by the lateral rotation. So now the 30 degrees it goes back. Then again it begins to spin backwards, okay, around the fixed transverse axis. Then slowly the posterior cruciate ligament loosens up. So sorry, the transverse axis moves backwards, and when the transverse axis moves backwards, then it is completely in a flexed position. Okay. Now a few more things that I want to mention here is that some tidbits. When the foot is on the ground, tibia is fixed. So femur rotates on the tibia, right? But when foot is off ground, tibia rotates. Okay, so the tibia rotates. So then what will happen is that the foot is on the ground. See, come to this last part. The medial femoral condyle rotates backwards and medially. This is when the foot is on ground. When it's off ground, the medial tibial condyle will rotate forwards and laterally. In the same way, when during the unlocking and flexion movement, okay, when the foot is on ground, lateral rotation of medial femoral condyle occurs. But when the foot is off ground, medial rotation of medial tibial condyle occurs. I hope you could understand what I said. Very easy to understand. Okay, now going on to two ligaments and the clinical anatomy. We will go on to first the cruciate ligaments. The cruciate ligaments, you have to know that they're intracapsular but extrasynovial. They are named as anterior and posterior according to their tibial attachments. Let me see if I can get that photo. I had a nice photo I'd taken here. Yes, this is the anterior part, this is the posterior part. So here you can see the anterior cruciate ligament, here you can see the posterior cruciate ligament getting attached. And these ligaments are taught at extremes of flexion and extension. Yes. Now we'll go into the detailed description. So anterior cruciate ligament first. Attachments. Anterior part of intercondylar area of tibia between anterior horns of medial and lateral menisci. This is the tibial attachment. Now the femoral attachment. Posterior part of medial surface of lateral condyle of femur. What are the functions? Binds bones together, stretch during extension, and thus prevents hyperextension, prevents forward displacement of tibial condyles. Forms a vertical axis around which femur rotates on tibia during extension or flexion of knee joint. Super. Now we are going to go to another guy. We may just choose the beside only. That is the posterior cruciate ligament. Attachments as usual. First is the tibial attachment below, posterior part of intercondylar area of tibia, behind posterior horns of both menisci. I hope you can see it here. This one. Above lateral surface of medial condyle of femur. Functions: binds bones of the joint, stretch during flexion, and prevents backward displacement of tibial condyles. Both cruciate ligaments prevent side to side displacement of femur and tibia. So this is all about the cruciate ligaments. Now we have some applied anatomy regarding the cruciate ligaments. Then we will move on to the menisci. See, anterior cruciate ligament tear will lead to a forward gliding. Okay, anterior cruciate ligament tear will lead to, see, we can see it here only, forward displacement of tibial. So forward displacement of tibial condyles. Similarly, posterior cruciate ligament tear will lead to backward displacement of tibial condyles. This is a very small part of the applied anatomy. Now we have to go to the menisci. Very important. Menisci. Then after going on to the menisci, I will tell you about some applied anatomy points which are actually a part of both. Means the menisci, it includes both the menisci, the cruciate ligaments, and it includes the collateral ligaments. Okay, you'll come to be composed of fibrocartilage, its incomplete partition, and intervene between condyles of femur and tibia. Moving on, these menisci divides condylar part into meniscofemoral and meniscotibial compartments. These two compartments. Going on to the medial meniscus. Which is the medial meniscus? This big guy over here, long guy over here, long guy, you can see him. This small guy is the lateral meniscus, medial lateral. Okay. As usual, presents anterior and posterior horns. See, have you seen any creature with anterior and posterior horns? I've seen like all the Rakshas and demons like with two horns. My God. And this is thing anterior and posterior horn. So like this anterior horn, posterior horn. Very funny depiction. Anyways. So presents anterior and posterior horns. Upper and lower surfaces, medial and lateral margins. See, again another viva point. Anybody asks you what are the parts of medial meniscus, you have to say anterior and posterior horn, upper and lower surface, medial and lateral margins. So viva points are everywhere. Anterior horn is narrower, okay. Upper surface is concave, lower surface is flat. Medial margin, do I need to even say it's convex? And then moving on to lateral meniscus. Same thing you will say anterior and posterior horns, upper and lower surfaces, medial and lateral margins. Okay. What important and separate point here is horns 4/5 of a circle. Both horns are of equal width. Here in the medial meniscus, the anterior horn was narrow, but here both horns are of equal width. Posterior horn. So the posterior horn is actually related to the popliteus muscle. Okay. So the posterior horn is related to the popliteus muscle. And yes, you know, the popliteus muscle pulls the meniscus backwards, so nothing much to state in that. So now coming on to the functions of the menisci. Increase concavity of tibial condyles for better adaptation with femoral condyles. See why this? If you see the femoral condyles now, they are much convex, whereas the tibial condyles are mostly flat. So it can't fit in place to place. So that's why the menisci are required. Maintain a potential joint space for flushing of synovial fluid. Why? To provide nutrition to articular cartilages, act as shock absorber, and help in the complex mechanism of gliding and angular movements. Okay. Nutrition of the menisci. Nutrition to the menisci. First year of life, menisci contain blood vessels throughout meniscal body. Meniscal body. Once weight bearing starts, once the child starts to stand, weight bearing starts, vascularity decreases, but it remains only in the outer 25 to 33% remains. After 50 years, of age, only periphery is vascularized. Periphery of meniscal body is vascularized. Central portion gets nutrition. From synovial fluid. Now going on to the applied anatomy. This one is applied anatomy, which relates with the menisci, the cruciate ligaments, the cross ligaments, okay, and the collateral ligaments. We'll see what are all these. See, the terrible triad of O'Donoghue. Tibial collateral ligament, medial meniscus, and the anterior cruciate ligament. How does it happen? Blow to lateral aspect of knee when foot is on ground. Sprains the tibial collateral ligament and medial meniscus may get torn. Okay, how does ACL tear occur? When already the TCL and medial meniscus are injured, so already the damage has been done. Okay, a blow to anterior aspect of knee joint. Now you know what happens when the ACL is torn. Anterior displacement of tibia from the femur, I've already mentioned. See, anterior displacement of tibial condyles from the femur. Okay. Injuries to menisci. How do they happen? Mostly occur in flexed knee, Then, how do they occur? Forcible rotation or abduction. Medial meniscus suffers more than lateral. Okay. Why? Because lateral has a greater range of movement. It is already protected by the popliteus muscle, right? Popliteus muscle pulls it backwards whenever there is danger. A greater range of movements, and the popliteus pulls it backwards, it prevents it from being trapped in the articular surfaces. Okay. Meniscal tears usually occur as bucket handle tears. So if this is the meniscus, then usually here is the tear. Okay. So this part, the medial part, you can see is getting detached. May get detached and displaced towards the center. Okay. So this is all about the ligaments which have been covered. Okay. The ligaments which have been covered, then the locking and unlocking mechanism which also has been covered, the Q angle which has been covered, and finally the complete knee joint also which has been covered. Yes. Thank you guys. So hello and welcome guys back to Physical Doctors. Today we are going to discuss about the veins of the lower limb. We are going to first begin with the great saphenous vein, then we'll move on to the small saphenous vein, and finally we will go to the inguinal lymph nodes. So here we can see a diagram of the great saphenous veins course. We can see the great saphenous vein is present here. This is the femoral vein, and from the femoral vein, the great saphenous vein is going as a branch. A superficial. It is the largest superficial vein of the lower limb. So we'll come to it when we discuss about it in details. Here you can see some tributaries which are going and joining, some perforators which are going and joining the vein. Sometimes they form an arch. Sometimes they form the posterior arch vein and join. Here you can see another perforator known as the anterior leg vein. Here you can see some other tributaries: superficial epigastric vein, superficial external vein, superficial circumflex iliac vein, So now let us get into the details of all of this. Right. So first of all, when we come to the great saphenous vein, it is the longest vein of the body, and it is the preaxial vein of the lower limb. Now we'll talk about its course. See, course of a vein usually begins at the lower point and then it travels up. Sorry. You can see it being mentioned over here. It begins as a continuation of dorsal venous artery foot. Passes upward in front of tibial malleolus, and crosses obliquely to the medial surface of lower 1/3 of tibia and ascends behind medial border to reach the knee. If you can see the course, if you trace the course, see it beginning from the dorsal venous artery, you can see the dorsal venous artery over here, and it's continuing. This is the tibial malleolus, so it is passing in front of the tibial malleolus, and then it is crossing over. You can see there's a little bit crossing over, okay, to the medial surface, and then it's going behind the medial border and reaching the knee. Here is the knee, okay, so it's going behind the medial border and reaching the knee. It is present posterior medial to knee joint. It's present. See, obliquely the leg is being shown, that's why I think you're not able to visualize properly maybe, but at least try to understand. Okay, so this is the anterior part of the knee joint, it's facing this way, so this part will be in an angular fashion posteriorly, no, so it's present in the medial side and slightly posterior, so that's why it's present in posterior medial way, right, present posterior medial to knee joint and runs upward along medial side of thigh to reach saphenous opening. So you can see the saphenous opening. You can see the saphenous opening over here. After piercing cribriform fascia, it drains into femoral vein. Any sort of a vein. Now this GSV is very important. GSV, SSV, more so GSV. GSV came in our class test also in anatomy. Now what are the structures related to it? Or structures accompanying? You may write this. Okay, it's not so much important, but considering the anatomical relations of any organ, you should keep them in mind. They may ask you a question if you want to make a difficult question. So few branches of medial femoral cutaneous nerve, saphenous branch of descending genicular artery. See, I hope you remember in the popliteal fossa also we were discussing about the saphenous branch of descending genicular artery, how it's related to the GSV and all. In adductor canal also I think we discussed about it. Okay. In saphenous nerve, in the discussion on nerves, we will also discuss about the saphenous nerve in relation to the GSV. Saphenous nerve in leg and foot. So a little bit of applied anatomy that I can state here, though there is a greater applied anatomy portion which can be stated a bit later. It can be stated together along with small saphenous vein also, but a small applied anatomy portion I'm writing over here. This is not much important. Much more important is the varicose veins. These are much more important. Okay, we'll come to it later. Venesection of GSV is done at ankle. Okay, so now the tributaries. Any vein you write, you must mention about its course, structures accompanying it, because it's anatomy. So then you have to mention about its tributaries, and few tidbit points you have to mention. Other big applied anatomies if you have, you must also mention them. Any other special points if you know, you can also mention. So tributaries are basically located in 3 parts. What are the 3 parts? So we'll have a look. See, some tributaries, they exist just below the knee level. Some exist in the thigh level. Okay, and some exist here, just before entering into the saphenous opening. That is just before piercing the cribriform fascia. And some are also present deep to the saphenous opening. That means behind the saphenous opening. Also, there is one vein which comes and joins. So we can basically divide it into 4 categories. So let's get writing. So first of all, A for the first category, just below knee. Who are those guys? Posterior arch vein. Posterior arch vein. Where does it collect blood from? It drains the blood from posterior medial aspect of calf. Super. Coming to the anterior leg veins. They move diagonally across the shin. They travel diagonally across the shin and they join it. Few veins from calf. What do? Communicate with small saphenous vein. So let's have a look at what we just discussed. Here we have the wonderful posterior arch vein, we have the anterior leg vein, and some few veins from calf. I can't see them. Some medial ankle perforators, you can see the perforating veins are present. In the thigh. Who are present in the thigh? Anterolateral vein from venous plexus on lower part of front of thigh. Posterior medial vein sometimes also known as accessory saphenous vein. If it communicates with SSV, if it doesn't, then it's known as posterior medial vein only. Some are present just before piercing the cribriform fascia. So what are they? Let's have a look. Superficial epigastric, then superficial circumflex iliac, and superficial external pudendal vein. So let's have a look at them. I think I didn't show you the thigh ones. Okay, so we'll begin with thigh ones. The anterolateral vein present here, as you can see, it's going on this course and joining. The posterior medial vein, which is this one, also known as accessory saphenous vein, is going and joining like this. So just before piercing the cribriform fascia, you can see the superficial circumflex iliac vein going like this. You can see the superficial external pudendal vein, which is joining like this, and you can see the superficial epigastric vein, which is joining like this. Wonderful. So coming on to deep to the saphenous opening. Deep external pudendal vein. Fun fact, it's not shown here. Okay, so you have to know it's present, but since it's a very deep-seated structure, so that's why it was not possible to draw it over here in the diagram. So you have to know it and you have to write about it. Okay, you should not miss on this. Now, what are the perforating veins which are present? What are the perforating veins which are present? You have two perforators, a mid-hunter perforator and a knee perforator. Okay, so let's have a look at them. See, you can see here there's the mid-hunter perforator and the knee perforator, which I have shown here, the knee perforator. Okay, now let us go into a bit more details of it, of the GSV. So what we can now do is learn about the mid-hunter. Then there are other perforators present. Sorry, I didn't mention about them. Okay, so after the knee perforator, there are three medial ankle perforators. I hope you can see them. See, let's have a look. You can see them. There's three medial ankle perforators. Wonderful. Let's go on over now to one lateral ankle perforator. Yes. Where is it? Let's search for it. Okay, it's not present. It should have been present somewhere here. See, it will go on from here to here. That's why, since it's a bit cumbersome, that's why they have not drawn it. This diagram is from AKD. Okay, so as I've already mentioned many times before, that AKD is definitely a very good book. So let us learn about another point. That is valves. Why we are talking about this point? Because this will be the basis of our clinical anatomy discussion, which is the varicose veins. So we have to know about the valves in the veins. About 10 to 20 valves are present in the great saphenous vein, among which one valve lies just before it pierces the cribriform fascia. A terminal valve is located at its junction with femoral vein. This is what is important, the terminal valve, also known as the saphenofemoral valve. Why saphenofemoral valve? Saphenofemoral valve because the great saphenous vein is ending and the femoral vein is beginning. So saphenofemoral valve. Functional importance. It has a functional importance. It is present in 80% people. And thus, they are protected against varicose veins. In the remaining 20%, they are more liable or more likely to develop varicose veins. Varicose vein is a clinical anatomical question which we will discuss later. Now, we will move on to the small saphenous vein. To the small saphenous vein we go. Off to the small saphenous vein. Let's write it wonderfully. Small saphenous vein. What I'll do is, I'll insert a photo. This photo is of the small saphenous vein. Wonderful photo. I'll make it big. You can see few things over here. That is the popliteal vein, which is my deep-seated vein. The small saphenous vein, which is going like this from the lateral side of the foot. This is the medial side. Make no mistake. So I hope you remember the dorsal venous arch, how the GSV was going. Okay, the GSV is going in front, and how the small saphenous vein is continuing from it and finally entering into the popliteal vein. A connecting vein may also be present, which connects it with the great saphenous vein. This is my lateral ankle perforator that we were talking about previously. It may join the small saphenous vein or it may join the great saphenous vein. That's why it was not shown in the earlier picture. I hope the confusion is clear now. So what we can do is, we can talk about its course first. Begins below and behind lateral malleolus as continuation of lateral end of a lateral end of dorsal venous arch. Yes, and it's also supplemented by the lateral marginal vein of foot. Supplemented by plus lateral marginal vein of foot. So it's an important tributary, it seems. It ascends along the lateral edge of tendocalcaneus, and accompanied by sural nerve on its lateral side. Thereafter the vein runs along middle of back of leg and undergoes a subfascial course between two heads of gastrocnemius. See, it pierces the fascia and then undergoes the subfascial course between the two heads of gastrocnemius and finally terminates into popliteal vein, accompanied by posterior femoral cutaneous nerve in upper part. Now we may talk about its variable termination. See, bodies vary, okay. Different bodies have different cadavers have different configurations, like what to say. This is configuration is not the correct word, I think. But anyways, like different human beings are different, right? Everybody is different. So everybody's veins also look different. They may begin differently, they may end differently. So that's why it also has a variable termination. I remember in our dissection class, our demonstrator madam once told us that she found a body which had the circumflex femoral artery arising directly out of the femoral artery and not out of profunda femoris artery. So that's also sometimes you may find. Okay. So sometimes it joins the great saphenous vein. Either directly or through accessory saphenous vein. I hope you can see in the middle. This is the accessory saphenous vein. Sometimes it may bifurcate, joining great saphenous vein, one joining the great saphenous vein and the other one ending in popliteal vein or other deep posterior veins of thigh. Occasionally, it may fail to reach the knee and end in GSV or deep veins of leg. Coming to the valves. Small saphenous vein provided with 17 to 13 valves. Okay, thank you guys for watching this video on the veins of the leg. So we have covered great saphenous vein and small saphenous vein. On the next video, we'll cover the varicosity, and later we'll also cover the inguinal lymph nodes. So hello and welcome to Physical Doctor. So now we're going to study the applied anatomy topic of the varicose veins. What are varicose veins? Superficial veins of the lower limb may get dilated and become varicose. The area of varicosity suffers from lack of nutrition, which culminates in a varicose ulcer, or which gives rise to a varicose ulcer. Such an ulcer may bleed profusely and require immediate surgical attention. Immediate surgical attention. Wonderful. Causes of varicosity. Thrombosis of the deep veins. See, there is thrombosis in the deep veins. The blood from superficial veins can't get into them, so the blood in the superficial veins would collect and the veins would dilate. Persistent elevation of intra-abdominal pressure due to abdominal tumors on multiple pregnancies. Incompetency of the valves in perforating veins. Or superficial veins, or both. This is the most common cause. Now we will go on to discuss a bit specifically, like suppose incompetency of the saphenofemoral valve. Incompetence of saphenofemoral valve. If the saphenofemoral valve is incompetent, more strain will be thrown on distal valves, and within a matter of time, and the whole saphenous vein, will become varicose. Big tension. Now there is a curative procedure known as the Trendelenburg's operation. Okay, I'm writing it here as an extra point. You don't need to state it. Trendelenburg's operation is the curative procedure. Trendelenburg's operation. Don't confuse it with the hip joint test known as Trendelenburg's test. Okay, it's not that. It's Trendelenburg's operation. It's a surgical procedure. The GSV is detached from femoral vein. At its point of entry, and its tributaries in the groin are ligated individually. This is the Trendelenburg's operation. Okay. Now, what if there is incompetence in the valves of the perforating veins? It will lead to high pressure leaks from deep to superficial vein, with eventual varicosity of the superficial vein. How is this treated? The site of defective perforators is identified and it is ligated. Okay, so treatment is identifying site of defective perforators and ligating them. If all the perforators of the GSV are involved, perforators of GSV are involved, the entire GSV is removed by stripping operation, where the entire vein is removed by a metal bar. Okay, you don't need to go into details of it. Now we can discuss about a nice test known as the tourniquet test or tourniquet test. What is it? Now, it is used for recognition of sites of incompetent valves. Recognition of sites of incompetent valves. Yes. See, the affected limb is elevated above level of heart. The patient is first made to lie down. Affected limb is elevated above level of heart to empty the varicose veins. A rubber tubing is applied. A rubber tubing or tourniquet is applied firmly around upper thigh to occlude GSV but not FV or femoral vein. The patient is now told to stand. Now allowed to stand up. Two possibilities may occur. If varicosity or the varicose vein remains empty for 30 seconds, communicating veins below the tourniquet or tubing are competent. If filling occurs within 30 seconds, the communicating veins are incompetent. With that, we finish our discussion on varicose veins. Okay, so we learned about what is varicosity, what are the causes of varicosity, what are the types we can have, like the saphenofemoral valve being incompetent, the valves of perforating veins may also be incompetent. And finally, we learned about the tourniquet test. Okay, thank you guys. Hope to see you on the inguinal lymph nodes in the next video, and we will continue later with the nerves also. So, hello and welcome guys. Today, we are going to discuss about another topic which is under veins only. This is the inguinal lymph node, which may come as a short note. Okay, this is a separate topic, it may come as a separate short note, though I am discussing it under veins, inguinal lymph nodes. Lymph nodes are very important. I hope you remember that in the upper limb, there were the axillary group of lymph nodes which are important. So let us first insert an image. See, these images are very easy to draw, but still I'm just not drawing them. Okay, but still very easy to draw. Okay, and you can definitely draw them. Okay, these photos from AKD. AKD always has the best diagrams, as I've told you. So inguinal lymph nodes are divided into a superficial group and a deep group with respect to fossa lata. You can see the superficial inguinal lymph nodes, upper group, superficial inguinal nodes, lower group. Okay, and then you have the deep inguinal nodes. Here, let's zoom in. This is the superficial one. This is the deep lower one. Okay, superficial, and this is the deep inguinal. So only 3 are present. Okay. This one. Sorry, these are the 3 deep lymph nodes. So first of all, let's go into the superficial lymph nodes, and then we will go over to the deep lymph nodes. Very small discussion. Superficial lymph nodes. What is important is you have to know their position and their afferents, efferents. Okay. Situated. Since these are superficial, so where will they be situated? In the subcutaneous fat. Easy only, no? Upper group. So we are now talking about this. Where is it located? Immediately below inguinal ligament. So you can see the inguinal ligament. Over here you can see the inguinal ligament, just below the inguinal ligament. Okay. Now, as I told you, they receive the afferents. Now the fun part about it is that the upper group and lower group have different afferents. Okay, but their efferents are the same. So we'll discuss the afferents differently, but we will discuss the efferents together. Right. So the upper group, what are the afferents? Let me use a different color, right? Yeah, we can use this one. So what are the afferents? So you can see that there are, in the upper group, there are few lateral members and few medial members. I think you are unable to understand. Let me show you another photo. It will be easier for you to understand that. This photo is difficult, you don't need to draw. I'll just keep this photo small, I'll zoom on it. See, what they say afferents for which group? The lateral members. You can see I'm talking about these guys over here. This is the lateral group and this is the medial group of the upper lymph nodes. I made a mistake. This is the lateral group, this is the medial group. So I'm not talking about the lateral members. They receive mainly their afferents from the gluteal region and from the adjoining anterior abdominal wall below umbilicus. I hope you remember the umbilicus, the watershed line. So mainly the lymphatics above umbilicus, then the umbilical nodes and other nodes which are present in the abdomen. And these guys, they drain over here, means below the umbilicus. Now the medial members. So we are talking about these guys over here. Medial members, see, it's the subcutaneous tissue of anterior abdominal wall below umbilicus. Same point. Anterior abdominal wall below umbilicus. Okay. Then you have the penis, including prepuce and scrotum in males, and vulva and vagina below hymen in females. You have the perineum and lower part of anal canal below pectinate line. Few uterine lymphatics. Mainly the lymphatics of uterus, they drain into the abdominal lymph nodes, right? I hope you can see these guys clearly. Okay. Now we are going on to the lower group. The lower group. Where is the lower group located? I used to get confused back in my time because the deep group was medial to the great stiffness vein and this one was lateral. But remember it's L and it's L, so lateral side of termination of GSV, great stiffness vein. Same thing. We are going to do with this also, afferents, because afferents are different. All superficial lymph vessels, I'm writing L vessels, okay, lymph vessels of lower limb, except vessels that follow small saphenous vein and end in popliteal nodes. So some vessels, they follow the small saphenous vein and in the popliteal nodes. Because in popliteal fossa, there were some lymph nodes and some fibrofatty tissue present, I hope you remember. Now we are going on to the afferents. So the efferents, the afferents are done. Now we go on to the efferents of both. So we are going to mark it like this. Let's see, the afferents we have done, now the efferents. Where do the efferents from these both nodes go? Efferents mainly go into external iliac nodes. Okay. Mainly they go along the efferents, yes. Then some traverse the femoral canal and go into the some traverse the femoral canal during their path. Okay, some traverse the femoral canal, and those are traversed by sorry, and they are intersected by the deep nodes. Separated by deep nodes. Some even pass lateral or in front of femoral vessels. Okay, so you can see that these mainly traverse the femoral canal and intersected by the deep nodes. Some even pass lateral to the femoral vessels. So if you remember the inguinal ring, this femoral sheath. So these were the femoral vessels, right? The femoral vein, the femoral artery, femoral vein. So from where does inguinal hernia take place? Inguinal hernia takes place to this location. So if these vessels are going like this, going lateral, so will they be affected by femoral hernia? They won't be affected by femoral hernia. So that's why you have to remember that femoral hernia does not affect them. The lymph vessels are not affected by femoral hernia. L vessels are not affected by femoral hernia. Now going on to the deep inguinal lymph nodes. Okay. Yeah. Deep lymph nodes. They are mainly 3 to 4 in number. Let's have a look. See, one present here, second present here, third present here. So only 3 in this case. 3 to 4 in number. Located medial side of femoral vein. Lowest lymph node is situated below junction of GSV and femoral vein. Middle node is in femoral canal, also known as gland of Cloquet, and the highest one is in lateral part of femoral ring with femoral septum, within the femoral septum. Same equation over here also. Some afferents, some efferents. Afferents. Deep lymph vessels which accompany femoral vessels. Glans penis or glans clitoridis, means lymph vessels from glans penis or glans clitoridis. Efferent vessels from superficial inguinal nodes. Where do the efferents go? External iliac nodes. Okay. Now let us go over to some clinical anatomy. The upper group of superficial inguinal nodes, they mainly get inflamed or enlarged due to infection or some malignant growth. Wow, what a nice sign. I never found that in my life. Malignant infection or malignant growth from infra-umbilical part of abdominal wall, gluteal region, perineal region. Perineal region also includes the genitalia. Okay. Genitalia, then the anal canal below the pectinate line. Lower group. This may get inflamed. Disease affecting lower limb. But the lymph nodes, that the lymph vessels which follow the small saphenous vein, though that region is saved. Otherwise, the lower group may get involved in any other diseases of the lower limb. Okay, so one more thing that I would like to add to this is that, suppose example, there is a syphilitic lesion of the prepuce of the penis. So in the prepuce of the penis, it usually involves the superficial nodes. Why? Because it's affecting the prepuce. Had it infected the glans penis, then there would have been the involvement of the deep nodes. But since only it's the prepuce part, the foreskin part, so it's only involving the superficial nodes. Okay, so this is all I would like to say in case of the inguinal lymph nodes. Thank you guys. So hello and welcome guys back to Physical Doctors. Today we are going to be reading about the nerves of the lower limb. We are going to first begin with obturator nerve, then we'll skip on to femoral nerve, and we can slowly enter into the saphenous nerve, which is actually a continuation of the femoral nerve. Finally we'll go on to the sciatic nerve, and we'll discuss about its two parts, the tibial nerve, common peroneal nerve. Finally we can slip into the superficial peroneal and deep peroneal nerve. Beginning with obturator nerve, we have a nice photo of the obturator nerve. The course of the obturator nerve is shown here. Let me just write it. Course and branches of obturator nerve. This diagram is actually borrowed from Snell's Clinical Anatomy. It's a wonderful book when it comes to the nerves. You should read Snell's Anatomy for this nerves part, and mostly the clinical anatomy is given very beautifully in Snell's Anatomy. Okay, So I won't tell you take too much patience now. That's why we are here, compiling all the information from the good books. So see, what is operator nerve? It is the nerve of the adductor compartment of thigh. Wonderful. Now, going on to its root value. Any nerve's root value is important. When you write about the root value, you have to write about some details. What are the root values? You can see L2, L3, L4. That's why diagram is important. You can always correlate, and this diagram is beautiful. If you write the answer, question comes regarding operator nerve, you have to draw this diagram. Okay. So what's the root value? Ventral branches of ventral rami. There is a ventral ramus and the posterior ramus. This ventral rami again gives ventral branches, posterior branches. So ventral branches of ventral rami of L2, L3, and L4. Super. Course. Coming to the course, what we can see, it is beginning in the abdomen, going on to the pelvis, dividing in the pelvis into two divisions, continuing in the adductor region of the thigh. So we'll discuss part by part like that. First of all, lies behind common iliac vessels in upper surface. So it's related to the upper surface of ala of sacrum, beneath medial border of psoas major. Operator nerve is a very easy nerve, lot less information compared to that femoral nerve. So much information. And sciatic nerve, my god, the biggest nerve. Okay, means the biggest in terms of information I feel. Okay, operator nerve is very easy nerve. You like studying about it. You can remember the details also very easy. So close to sacroiliac joint, it lies lateral to internal iliac vessels and pelvic part of ureter, and occupies floor or lateral wall of ovarian fossa in females. You know what? This is a very important viva point. Okay, lateral wall of ovarian fossa in females. Okay, floor or lateral wall of ovarian fossa in females. This is a very important viva point. Very important viva point. Clinical anatomy correlation is also present in this point. We'll complete when we discuss about the clinical anatomy. This is very interesting nerve. You like it. Very easy to correlate also. Not excess information like femoral nerve or sciatic nerve. You can correlate this nerve very easily. It leaves pelvic cavity through obturator canal and accompanied below by obturator vessels. In thigh, nerve splits into anterior and posterior division. Okay, and how do you understand this anterior and posterior division? Adductor brevis muscle and obturator externus muscle intervene between two divisions. That's how you differentiate the anterior from the posterior division. In anterior to the obturator externus and adductor brevis, you will find the anterior division, posterior to it will be the posterior division. So let's correlate with the diagram. Here is the anterior division, here is the posterior division. Here you can see the peritoneum on lateral wall of pelvis. Coming over to the branches. So branches are definitely divided into two parts. Why? Some are the anterior division branches, some are the posterior division branches. Mainly we will see that this is related to the adductor muscles only. So going on to the branches of the anterior division. Lower border of adductor brevis. It joins subsartorial plexus. See, lower border adductor brevis. This is the subsartorial plexus. I hope you remember in the class on adductor canal where it was shown that in the roof of the adductor canal there is a subsartorial plexus which usually gets a branch from the anterior division of this obturator nerve. Close to obturator canal, it gives articular twigs to hip joint. Muscular branches to adductor longus, brevis, medial part of pectineus, and gracilis. Finally, it ramifies on femoral artery. See, you can see the branches going to adductor longus, adductor brevis, gracilis, finally going on to femoral artery. This is the benefit of a diagram. As I always say, you can always correlate with the diagram. Writing answers becomes easier for you in the presence of a diagram. Going on to the posterior division. Supplies these muscles. What muscles? Adductor magnus or adductor part of adductor magnus. Adductor part. Because the hamstring part of the ischial fibers they are supplied by the tibial nerve. Obturator externus. What else? It may supply. See, if adductor brevis is not being supplied by the anterior division, only then the posterior division comes and supplies it. Right? It's like you can't do business with one trader, so you shift to another trader. Anyways, so it may supply adductor brevis. If it is not already supplied by anterior division. Again, this gives an articular branch to knee joint, but then we can discuss about it later. Going on, it gives genicular branch to articular capsule of knee joint, okay, and cruciate ligaments in knee joint. You can see the articular branch has been marked here. Finally, the popliteal artery. So vascular branch to popliteal vessels. Finally, going on to its applied anatomy. So what is the applied anatomy? Many three interesting applied anatomical situations we can see over here. Very interesting. You can easily correlate. This is my favorite nerve. This is my favorite nerve. Okay. If they used to give shortened anytime in the first year regarding this, I would have easily written one complete page. Means not one complete page. I would have written the complete answer. So, see the interesting part. In diseases of hip joint, pain may be referred to medial side of thigh or knee joint along obturator nerve, because you can see obturator nerve supplies the hip joint, also the knee joint. So pain of the hip joint can be referred to the knee joint. If you see a patient with knee joint pain, you should always suspect there might be something wrong. And if they say the medial side of the knee joint, medial side of thigh, the pain is coming, something is wrong, fishy with the hip, maybe, because it's traveling along the obturator nerve. In spastic paralysis, obturator nerve may be divided surgically to relieve spasm of adductor muscles. Now coming to the most important clinical anatomy part. In inflammation of ovary, I remember in our first year one sir said that suppose there is a patient who is coming to you. Okay, wait, I'm just finishing this point. So localized peritonitis, which may affect the ovarian fossa with eventual irritation of obturator nerve. This is a viva point also, very important clinical anatomy point also. Pain in such condition may get referred to hip joint, knee joint, or inner side of thigh. So what our sir said is, suppose a patient has come complaining of pain in both hip joint and knee joint together, and the medial side of the leg or the medial side of the knee joint is paining, or the hip joint and medial side of the knee joint are paining together. Female patient is right. So you have to suspect something is wrong with the ovary. So see, you remember this point. You see, yeah, floral lateral wall of ovarian fossa in females. So because it's related to the floral lateral wall of the ovarian fossa in females, pain is getting referred from that point straight to the hip joint and the knee joint. Hip joint and knee joint. Wonderful. Okay. So now we have discussed about the femoral nerve, and we'll discuss about the saphenous nerve along with it. Femoral nerve is the largest branch of the lumbar plexus. Okay. Femoral nerve and the saphenous nerve is the longest cutaneous nerve of the body. When we come to the saphenous nerve, I hope you can see mainly the skin is being supplied. All cutaneous supply of saphenous nerve. See from here the saphenous nerve is beginning. So all this is saphenous nerve. So you know this diagram is also borrowed from Snell, and this is the diagram of AKD. This is the diagram you don't need to draw. This is for your understanding purposes, correlation purposes only I have kept here. Okay, but this diagram is very important. If ever question comes regarding femoral nerve, you have to draw this diagram. Okay, coming over to this diagram, I told you it's borrowed from Snell's clinical anatomy. So Snell's clinical anatomy usually shows femoral nerve as a single branch, but I have developed it a bit more, and I have shown, and I have gone according to the books, conventional books of India. Okay, mainly BDC, Vishram Singh AKD, and I have shown an anterior division and a posterior division. Okay, let's get into it. So this largest branch of lumbar plexus and nerve of extensor compartment of thigh. What we can go now to see, a nerve has the basic points: root value, course, branches, applied. So since we have discussed the tidbits, we can go over to the root value. Mind you, we will discuss saphenous nerve along with this only. Why? Because saphenous nerve is a part of femoral nerve. However, it may come as a separate short note. If you are writing femoral nerve, it will be a huge short note, because you will include that part of saphenous nerve also. Saphenous nerve is actually contains details which you can't omit in femoral nerve, right? Because femoral nerve is going. Now where is it going? It's going as the saphenous nerve, so you have to write about the saphenous nerve. You can't omit some details, right? Root value arises from dorsal branches. I hope you remember obturator nerve arises from the ventral branches of ventral rami, but this arises from the dorsal branches of ventral rami of L2, L3, L4. Now we go on to the course. The trunk appears in the iliac fossa under cover of fascia iliaca in the interval between the psoas major and iliacus. Trunk of nerve appears in iliac fossa under cover of fascia iliaca between psoas major and iliacus. Super. It is separated from femoral artery by psoas major tendon. Trunk of nerve splits 2 to 3 centimeter below inguinal ligament by lateral circumflex femoral artery into anterior and posterior divisions. See, that's why now I have this diagram in picture. This is my beautiful ligament, inguinal ligament. Below it, my trunk, my femoral nerve trunk is coming 2 to 3 centimeters. You can see this person over here. This is my lateral circumflex femoral artery. Here is my anterior division. Here is my posterior division. This is a diagram from AKD. Anterior division is going to so many places. Posterior division is going to many more places. Anyways, that was a lame joke. So this is where the femoral artery my femoral nerve basically ends. Okay, this is as much as we know about the femoral nerve's course. So now we can go over to its branches, and that is where things get lengthy and a bit more complicated. Branches. So what are the types of branches that we have? See, if you focus on this diagram which I have drawn, this is the trunk. So there are some branches from the trunk, some from the anterior division, some from the posterior division. Now this anterior division also gives off these three guys you can see. Among them, this medial guy again divides into two parts, anterior branch, posterior branch. However, we will discuss about it in very little detail, that much is not important. So let's go over, and you know that clinical anatomy of femoral nerve is not that much important. Femoral nerve is very deep seated. So usually you can't, fiddle and, irritate it in any way, fiddle with it or irritate it in any way. So let's go to the branches from the trunk. 3 branches. 1 to iliacus, next to pectineus, few vascular branches. To femoral artery. Nerve to pectineus supplies lateral part of pectineus. Medial part of pectineus is already being supplied by this person. Medial part of pectineus is already being supplied by my operator nerve. So lateral part of pectineus is what is remaining. Such a small muscle gets so many supplies. My God. From the anterior division. So now we go over to the lower part. From the anterior division, I hope you can see the anterior division. It's here. It's standing out. Different than everyone else. Just a plain nerve with some supplies. What is it different? But anyways, let us not discuss their personalities and let us get into their theory parts. See, it gives off 2 cutaneous branches and 2 cutaneous branches. Intermediate femoral cutaneous nerve, also known as intermediate cutaneous nerve of the thigh. So not much theory regarding it. Then we go on to the medial femoral cutaneous nerve. Very versatile branch, this one. Very irritating. Anything which is versatile, anatomy is going to be irritating. Why? Because it presents with a lot of information. Let's go. Lot of information. I'm not going to write about the other part here. See, this actually in a medial femoral cutaneous nerve. It is present at lateral side of femoral artery, at apex of femoral triangle. From there, it goes to the lateral side, goes to medial side, from the lateral side, and divides into anterior and posterior branches. Anterior branch, posterior branch. Don't get confused. These are the anterior and posterior branches of the medial femoral cutaneous nerve, which is a branch of the anterior division of the femoral nerve. I know, sounds too much. I'm also feeling it, but it's confusing yet important. What the anterior branch does is, it descends in front of sartorius. Okay, and then it actually again divides into 2 branches, but okay, you don't need to go into that much detail. Supplies medial side of knee and lateral side of patella. Its branches, okay. It divides into 2 branches. One goes to the lateral side of patella, one goes to the medial side of knee. You may remember it as a Viva point, but it's too much detail. You don't need to know at this level. And communicates with infrapatellar branch of saphenous nerve. See, I'm showing you one thing. This is the human being. Sorry, this is the nerve. Okay, infrapatellar branch of the saphenous nerve. This is the saphenous nerve. So this is the infrapatellar branch of the saphenous nerve. This guy. So here the medial, this guy is giving a branch anterior division, which is again going and communicating with it. I hope you understood. Going to the posterior branch, gives few twigs to subsartorial plexus. and supplies medial side of upper part of leg. Finally, we have another branch which is the nerve to sartorius. It may arise independently as I have shown here, or it may come from intermediate cutaneous nerve of the thigh. Going on to the posterior division. From the posterior division. Posterior division gives branch saphenous nerve, which we will discuss in detail right now, and quadriceps femoris, the muscular branches to quadriceps femoris. We will discuss about the muscular branches to quadriceps femoris also, but right now we will be discussing about the saphenous nerve. Saphenous nerve, let me mark it in. Let me mark it in. Saphenous nerve may come as a separate. Okay, this is looking bizarre. May come as a separate short note. So now we are going to learn about the saphenous nerve. Saphenous nerve. I will go on to this saphenous nerve, and I will go on to this saphenous nerve. You can see the communication here. Okay, you can also, I guess, see the communication here also. So my dear saphenous nerve is here. Yes, my dear saphenous nerve is here. Dear and here. Wow. What we are going to write about it? It's the longest cutaneous nerve of the body, as I had already mentioned. We are going to write about its course. Extends downwards along lateral side of femoral artery in femoral triangle and upper part of adductor canal. The nerve crosses in front of the femoral artery from lateral to medial side, middle of the adductor canal. Middle of adductor canal. Cross from lateral to medial side. Finally leaves the lower part of the canal. Lower part of the canal by piercing fascial loop. Yes. Accompanied by saphenous branch of descending genicular artery, I hope you remember. And it gives off a branch to form the subsartorial plexus. Gives off a branch to subsartorial plexus while leaving the adductor canal. What more can I expect? Now, this is before the knee. Going on to the knee, it's in the thigh. Going on to the knee, it is present on the posterior medial surface of knee. Saphenous nerve pierces fascia lata and gives off infrapatellar branch. See, since it's actually a discussion about a nerve within a nerve, a bigger nerve. So saphenous nerve, I'm discussing it within my femoral nerve. So I'm discussing it a bit in a compressed manner. I'm discussing the branches along with the course. I hope you can correlate. I'll definitely go to the diagram. So posterior medial surface of knee, saphenous nerve pierces fascia lata and gives off an infrapatellar branch. Infrapatellar branch to skin. Going over, this infrapatellar branch supplies skin in front of patella, and it also communicates with the other nerves which we discussed previously. Then saphenous nerve accompanies great saphenous vein line first behind, then in front of the vein, and passes down medial side of the leg along medial border of tibia. Medial border of tibia. Let's have a look at the diagram present here. See, this diagram I have shown for correlation only. So if we have the GSV coming here, okay, this is the femoral vein, supposing this is the GSV. So if you look at the saphenous nerve, first it's going behind, then it's crossing over and coming in front of the vein. This is my vein and this is my nerve. Okay. Now, in lower third of the leg, lower 1/3 of the leg, it divides into two branches. One branch follows medial border of tibia and extends into the ankle, extends up to the ankle. Other branch passes in front of ankle and supplies skin on medial side of dorsum of foot up to ball of great toe. We had shown this in the diagram which I had drawn. I'll show one to show 2. Going over here, this point, it divides following the tibia to skin of medial side of leg, and the other one goes into the medial side of foot up to ball of big toe. See, so easy when you have a diagram to correlate with. Finally, going on to the muscle. Finally, see, saphenous nerve as a short note is prepared. Saphenous nerve as a part of femoral nerve, if you have to write, is prepared. What we can finally go to is the muscular branches to quadriceps. I hope I remember I had told about it. This one, not that important, but then you should know about it. 4 branches will exist. One will go to rectus femoris. So this is the nerve to rectus femoris. Okay, the nerve to rectus femoris also gives a proprioceptive joint position sense. Okay, proprioception is joint position sense. Proprioceptive branch to hip joint. Nerve to vastus medialis. Okay, this gives a proprioceptive branch to knee joint. Just these parts are only important. Okay, you don't need to know about the details of how they enter the muscle, from which side they enter the muscle, okay, whether they enter from the front door of the muscle or from the back door of the muscle, or whether they break the window of the muscle and enter the muscle. You don't need to know about all that. Okay, too much details. We are not discussing property buildings over here. It's a bad joke again. Nerve to vastus lateralis. So this is actually accompanied by descending branch from lateral circumflex femoral artery, gives an articular twig to knee joint. Vastus intermedius, nerve to vastus intermedius. See, this nerve to vastus intermedius also supplies articularis genu muscle. 2 small muscles, okay, articularis genu. Articular branches to knee joint. In this photo, I can see the rectus femoris being supplied. Okay, the other vasti are not shown here. So this is all about the discussion on the femoral nerve. Thank you guys. So, hello and welcome guys. Today we are going to discuss about the sciatic nerve first. Going on to the sciatic nerve, I'll be moving on to the tibial nerve, and from the tibial nerve we'll go on to the common peroneal nerve, and from the common peroneal nerve we'll go to the superficial and deep peroneal nerve. Coming to the sciatic nerve, I am not starting off with a diagram because, see, in the tibial nerve there will be a diagram with the same starting. In the common peroneal nerve also there will be a diagram with the same root values. Okay, so if I basically now draw a diagram, you will be left with a clumsy mess in your copy if you're copying it down with me, or I'll be left with a clumsy mess on my board which I'm writing. So that's why I don't want to take the risk of drawing the diagram of the sciatic nerve. Anyways, however, I'll tell about its details, and after discussing its details we'll definitely go on to the tibial nerve and the common peroneal nerve, where we definitely can see the diagram. Have a look at the wonderful diagram. It's also a diagram that I borrowed from Snell. So let's get cracking once again. Yes. So coming to the sciatic nerve, it's the widest nerve of the body. It is the thickest nerve of the body. Usually it consists of 2 trunks, right? The tibial component and the common component. Just as I mentioned, it begins together only. In a common trunk it's enclosed. So that's why I'm not going specifically about the diagram as I told. So let us first go to the basic information. So imagine 2 centimeter thick nerve, right? Consists of 2 components, tibial and common peroneal. Now you can also mention from which root values of the tibial and common peroneal, but I am not mentioning it. Why? Because I will again repeat it in the tibial and common peroneal nerves. So I want to be specific there. I don't want to be specific here right now. It emerges to the greater sciatic foramen. Velo piriformis. I hope you remember the relations which I have taught. Okay. In gluteal region, it rests successively on body of ischium, dorsal surface of body of ischium, but anyways separated by nerve to quadratus femoris, tricipital tendon and other related to. So let's get back to it. Yes, sorry for the disturbance. Separated by nerve to quadratus femoris, and tricipital tendon is there. at the back of the thigh. Okay, sciatic nerve is crossed superficially by long head of biceps femoris, and it divides into tibial and common peroneal nerves at upper angle of popliteal fossa. A special type of, or a absurd type of division of the sciatic nerve also may take place. Division of sciatic nerve may also take place in pelvic cavity. Then common peroneal nerve pierces piriformis, and tibial nerve emerges below the muscle. Yes. So, going on to the branches. Muscular, mainly to the hamstrings. Medial side of nerve to hamstrings. Articular to hip joint. One very funny fact about this, or some fun fact, I would say funny fact. Fun fact. Medial side of the nerve is dangerous. Medial side is dangerous. Lateral side of the nerve is safe. Why is medial side dangerous? Because all the muscular branches arise from the medial side. Now going on to some applied anatomy of this sciatic nerve. Applied anatomy of sciatic nerve. Usually sciatic nerve, some compression, some irritation can cause the problem. Let me now write down regarding this. So what we can do is sciatic nerve, right? See, the sciatic nerve can be injured by penetrating wounds. Or lacerating injury, as they say. Dislocation of the hip joint. Or fracture of pelvis. So what are the effects? Motor loss, sensory loss. Inability to extend the thigh and flex the leg due to deep paralysis of hamstring muscle. Paralysis of hamstrings. This is the first point. Second point, in motor loss. Loss of all movements below the knee and foot drop due to paralysis of all muscles of leg and foot. Going on to sensory loss. Back of the thigh, whole of leg and foot. Why? Due to involvement of cutaneous nerves. Cutaneous branches of sciatic nerve and its descendants. Now we go on to another clinical anatomy known as sciatica. It is given very beautifully in Vishram Singh. Shooting pain felt along the course and distribution of the sciatic nerve. Along course and distribution of sciatic nerve. See, wherever the sciatic nerve is present, it will cause pain there, like in the buttock, posterior aspect of the thigh, lateral aspect of the leg, dorsum of the foot. Cause of sciatica: compression of spinal nerve roots, L4 to S3, by a herniated intervertebral disc. Okay, so this is all about the sciatic nerve. Now we'll go on to its branches. So hello guys, welcome back. Now we are here at the tibial nerve. You can see that these are the nerve roots from which the tibial nerve is forming, going about like this, giving a sural nerve, and then continuing as the lateral and median plantar nerve. Median plantar nerve and all these are not so much important, that's why we have not written about details about their branches. They also have some muscular supply. Okay, they mainly have the muscular, and this one supplies the skin, this branch. You don't need to bother much about that. What we need to bother about is in this discussion from here up to this part is in itself a humongous part. This cylindrical structure which you can see is my sciatic nerve. It has got both the tibial and the common peroneal components. I just discussed about sciatic nerve earlier. So let's get into the tibial nerve now. Let's get into the tibial. What we can say here is that root values of the tibial nerve, ventral branches of ventral rami of L4, L5, S1, S2, S3. It supplies posterior crural region. Why it supplies the posterior crural region? Mainly you can see that the tibial nerve emerges as a separate entity of itself after the popliteal fossa. So it's remaining in the leg, in the crural part. So it is a nerve of the posterior compartment. So it supplies the posterior crural region, accompanied by posterior tibial vessels under cover of tendinous origin of soleus. See, its course mainly begins, or its life mainly begins in the popliteal fossa. So we are going to go into the popliteal fossa to discuss about it. It lies lateral to popliteal vessels in the upper part, but crosses to medial side of the vessels. Now what we are going to do, we are going to look at a photo of the which is taken from the popliteal fossa. So let's get to that photo first. Yes, so we'll go into the photo now. Yes, what we're going to do is now we're going to save the photo. Sorry. Yes. So here we have the photo of the popliteal fossa. Let's go and let's try to find out the tibial nerve, which is located here. Here you can see the tibial nerve is going. These are the vessels. This is the medial side. This is the lateral side. So yes, it is going lateral, crossing over and coming to the medial side. Sural nerve is a branch from it. Yes, sural nerve is a branch from it. Then it's joining the sural communicating another nerves. What's important to see is that it's coming from the lateral to the medial side. Now, what are its branches in the popliteal fossa? Muscular. What are the muscular branches? See, located just here. So what we can do is we can talk about them: gastrocnemius, soleus, plantaris, popliteus. These four guys. So we'll write about them: gastrocnemius, plantaris, soleus, popliteus. Wow. These are the branches from lateral side. Remember, in the back of the thigh, tibial nerve was giving branches from the medial side. So we said that the medial side of sciatic nerve in the back of the thigh is dangerous. However, here it's giving the lateral side. So lateral side of tibial nerve is dangerous. Just a viva question might come. Some articular branches we have. What are they? Superior and inferior medial genicular nerves. Another branch is the medial genicular nerve. If we see here, these are the branches we are talking about. Okay, these are the nerves that we are talking about. This one, this is going and supplying this muscle. I'm not talking about this one. I'm talking about these three. A cutaneous branch is given, which is known as the sural nerve. Vascular branches to popliteal vessels. Now when it goes over to the posterior compartment of leg, give some branches there also. Muscular to tibialis posterior, flexor digitorum longus, flexor hallucis longus. Articular to ankle joint. Finally, it divides into medial and lateral plantar nerve in sole. You can see the medial and lateral plantar nerve I have marked here, but then it's not in required in details now, so you don't need to bother about it. Here is the TP, the FDL, FHL, branch to ankle joint, and some to skin of ankle joint. Moving on to tibial nerves applied anatomy. Okay, so what can be the applied anatomy? Just basic compression. That will only be more than enough for applied anatomy, right? If you look here, see, if tibial nerve is injured, it may result in motor paralysis of all the muscles that it supplies. What are the muscles it supplies? It supplies gastrocnemius, soleus, popliteus, tibialis posterior, flexor digitorum longus, flexor hallucis longus, and all intrinsic muscles of the foot. Except extensor digitorum brevis. You have to remember this. What happens as a result of this motor paralysis? As a result of it, foot is dorsiflexed at ankle joint and held in eversion due to unopposed action of the peroneus muscles, due to unopposed action of the other anterior muscles like tibialis anterior and all those muscles which are mainly supplied from the common peroneal nerve. So due to mainly actions of the unopposed action of the common peroneal nerve supply, the foot is held in dorsiflexed and in everted posture. Right, person cannot stand on his toes. See, tibial nerve basically supplies the intrinsic muscles of the foot. Okay, due to involvement of intrinsic muscles of the foot. Sensory loss occurs. Entire sole and dorsal aspect of terminal phalanges leads to trophic ulcers. So this is how we are done now with the tibial nerve. Thank you guys. So hello guys, welcome to another discussion. Today we are going to discuss about the common peroneal nerve. Along with the common peroneal nerve, we'll discuss about the superficial peroneal nerve and the deep peroneal nerve. So the common peroneal nerve usually goes to the anterior compartment. In the anterior compartment divides into superficial and deep peroneal nerve. Now superficial peroneal nerve is actually the nerve of the peroneal compartment of the leg or the fibular compartment of the leg. You can see it supplies the peroneus longus, peroneus brevis. The deep peroneal nerve is actually the nerve of the anterior compartment of the leg. Tibialis anterior, extensor hallucis longus, extensor digitorum longus, peroneus tertius are being supplied by him. So, and even extensor digitorum brevis are being supplied. And some cutaneous nerve is also given off. Let's go over and with this structure in mind. This is a structure which is borrowed from Snell. Okay, I've taken it from Snell's Clinical Anatomy. Wonderful book. If you really want to see these types of structures of the nerves and all, very beautiful diagrams are being. So first of all, root values. As I always mention, root values. Dorsal branches of ventral rami of L4, L5, S1, S2, S3, and you know it divides into deep and superficial peroneal nerves. See, not much it supplies. Okay, it doesn't supply too much. It just has few 2 to 3 supplies, so not much about detail. Like tibial nerve had a huge deal of a supply. Like it was supplying the entire posterior aspect of the leg, but in this case, it only supplies a very small part and then only divides. The real guys which are supplying the anterior and peroneal compartments of the leg are the superficial and deep peroneal nerve. So they deserve more credit, more information to them. So not much information to this guy over here. So branches cutaneous. You can see one branch over here. Sural communicating branch. Sural communicating nerve and lateral sural nerve. What is the lateral sural nerve? Lateral nerve of calf. That's the lateral sural nerve. Okay. Articular branches. Superficial and inferior lateral genicular nerve. Recurrent genicular nerve. If I bring that photo over here, I hope you remember that one. See, I had pasted it before also. Here I'm bringing it again for you. First, what I would like to tell is that I hope you can understand this part. Now, this is the pelvis portion. This is the gluteal region portion. This portion is the back of the thigh. And finally, this is the lower leg portion. Lower leg has been marked here. This is the foot portion. So let's get into it. This is the common peroneal nerve. You can see the genicular branches. Here, you can see the cutaneous nerve, sural communicating nerve. Another one, this is the lateral sural nerve actually, yes. See, the lateral cutaneous branches of the calf, also known as the lateral sural nerve. I've written it here, I'll reinforce it. Lateral sural nerve. So this is all about the common peroneal nerve. Nothing much clinical anatomy about the common peroneal nerve. Let's go over to another easy nerve out there, which is the superficial peroneal nerve. Superficial peroneal nerve. Actually, if anybody asks you to write, suppose superficial peroneal nerve, short note, you have to always begin from the root value. So you have to give this root value which is mentioned here. Then onwards, you have to say that it is a branch of the common peroneal nerve. You have to say that from where common peroneal nerve is arising. Then you have to say that it's a branch of the common peroneal nerve in the back of the thigh. Okay, the back portion of the knee joint. It's arising from here. Okay, then you have to say, and then you have to go into the main substance of the superficial peroneal nerve. Then you can say that arises from superficial division of common peroneal nerve. Muscular supply, peroneus longus, peroneus brevis, and finally Other supplies, pierces, deep fascia, okay, behind anterior intermuscular septum. Finally supplies skin of lower part of leg, divides into medial and lateral branches to supply skin of dorsum of foot. Very important. If you see the diagram of foot, is the dorsum of the foot is actually supplied by the superficial peroneal nerve. Now we can go on to the deep peroneal nerve. We write about its course. Spirals around neck of fibula, pierces anterior IM septum, intermuscular septum, and appears in anterior crural region. It descends through leg down to ankle, beneath extensor retinaculum, and divides into medial and lateral terminal branches. I think we can see that in the end. Okay, this division. Branches, muscular supply, anterior crural region, all muscles of anterior crural region, okay, articular to ankle joint. Now we'll discuss about the branches. Lateral terminal branch forms a pseudoganglion through which it supplies the muscle and divides into interosseous branch to supply tarsal and metatarso-phalangeal joint of middle three toes. Medial terminal branch supplies first dorsal interosseous muscle and first metatarso-phalangeal joint and skin between great and second toe. Going on to the applied anatomy, let's have a look at the applied anatomy of the superficial peroneal nerve. The deep peroneal nerve. Okay. Anterior leg syndrome, excessive accumulation of tissue fluid in anterior compartment of leg due to exertion. Okay. This is basically an applied anatomy of the anterior compartment of the leg. Okay, this is what we can actually give about the deep peroneal nerve. It's a deep-seated nerve, not much irritated by any kind of problems. However, if we go over to the common peroneal nerve, we can get some basic clinical anatomy. So, going over to the common peroneal nerve and its applied anatomy actually. Yes, applied anatomy under the common peroneal nerve. It usually covers up. Okay, it will cover up both for the superficial and deep peroneal nerve. Injury to the common peroneal nerve is most common. Injury to common peroneal nerve is most common and most important also. Why because see, neck of fibula is a very superficial structure. If you just touch the lateral aspect of your knee, a little bit below, you can feel the neck of the fibula. And mainly this common peroneal nerve, its descendants like the superficial peroneal nerve, they usually actually cross over or spiral around the neck of the fibula. So you can easily press to create a compression and irritate the nerve easily. Okay, so that's why most clinical anatomical questions regarding fracture of knee joint related something, it will come regarding this only. Some may say fractured neck fibula. Now what will happen? So common peroneal nerve will be destroyed or irritated. There will be foot drop. Very important. I'm coming to it. We'll understand. Very easy to correlate. Yes. Most common. How is it involved? Involved in fracture, neck fibula, or pressure of a plaster cast. Going over from here to here. Motor paralysis may be observed. Motor paralysis. All muscles of anterior compartment and peroneal compartment. also known as the extensor compartment or peroneal compartment. See, the posterior one is the flexor compartment, anterior one is the extensor compartment. You may write extensor compartment, it's a better word. And this one including extensor digitorum brevis. You can see the supply over here, right? Results in foot drop. Very important, very important. Ankle is fully plantar flexed. Foot is inverted and adducted. The interossei muscles are not disturbed. Why? Because they're supplied by the tibial nerve. So the interossei muscles are okay. So what we can basically do is, we are falling short on space, right? It's okay. You have to know in this case, however, dorsiflexion of middle and terminal phalanges is retained by lumbricals and interossei. Going over to the second point, this one is the first one, now sensory loss. Most of dorsum of foot and outer surface of lower 1/3 of front of leg. Done. Now, so as you can see, the fracture to neck fibula can result in this case of the common peroneal nerve, right? So we have covered the peroneal nerve, okay, we have covered superficial peroneal nerve, and we have covered the common peroneal nerve. So thank you guys. See, one more point that I would like to add: pseudoganglion. You know other places where there's pseudoganglion in the upper limb mainly. In the upper limb, do you know where there's pseudoganglion? Probably it was somewhere in the axillary nerve. You'll get to know about it in the classes on upper limb. Very important. You have to know where the pseudoganglions are. They may ask you as a viva question. Okay, guys. So thank you. So now we are going to have a quick discussion. Let's look at this. A quick discussion on the lower limb. So structures under the cover of the extensor retinaculum of the lower limb. To be more specific, here, inferior extensor retinaculum. That is this one. This structure. So what are the structures that we can see? I hope you can see this structure. This is the tibialis anterior, so we note it down. Moving on, the next structure is this. Extensor hallucis longus. Extensor hallucis longus. Then we have this. Actually, I wouldn't mark it because I want it to be clear for you. It's the anterior tibial artery. Moving on, the next structure. That's this. The deep peroneal nerve. Nice. Then we have this person who is dividing. Extensor digitorum longus. And we have the last one who is the peroneus longus. So going on to the age-old mnemonic, we are revising once again. What's it? The Himalayas are never dry places. Though it's covered in ice and it's actually dry, but still. So in order to make a mnemonic so that you can easily remember, right? Moving on. Let me be clear about this one. This is the medial side, this is the lateral side. So when I go from medial to lateral, okay, let's show you here also. This is the medial side, this is the lateral side. Here also we went from medial to lateral. Here also we are going medial to lateral. What do we find here? Right, we find the tibialis posterior first. And then we find the flexor digitorum longus. Though it's crossing over, but just beneath the flexor retinaculum. So beneath the flexor retinaculum. Okay, this is beneath the inferior extensor retinaculum of the lower leg. Yes, flexor digitorum longus. Then we have an artery, posterior tibial artery. Then we have a nerve, the tibial nerve. Finally, I have the flexor hallucis longus tendon. So going over the same logic again. we can create a nice mnemonic. Again, age old. Tom, Dick. I'm writing it down here. It will be easy for you to understand. See, it's Tom, Dick, and Harry. Tom, Dick, and Harry. Three friends, Tom, Dick, and Harry. So, the two mnemonics that we have, the Himalayas are pneumatolysis, and Tom, Dick, and Harry. Thank you.